beside him, Dr. Matthew Burge, you've also met too. Some of you will know our next person on our panel, Helen, who is a specialist nurse from Brisbane, so thank you, Helen. And beside Helen, we've got Paul, and is it, I didn't ask you how to pronounce your name. Klages. So Paul is a pharmacist, and I think it's actually really exciting to have a pharmacist on our multidisciplinary team. Sometimes they're a bit of a neglected member of our team, but they actually have quite a significant body of expertise, and so thank you. And beside Paul, we've got Stephen Nocher, who's another one of our specialist nurses from Royal Brisbane who works with the new Clean team, so welcome, Stephen. David Pattison, you've met one of the other Davids, and beside David is Dr. Amanda Love, who is one of our other medical experts, and I'm sure Amanda will be able to tell you a bit more about her role shortly. And just to cap the Davids off, I think, because we couldn't have enough Davids, we've got a surgeon, Dr. David Cavallucci, on the end there. So I'm really looking forward to hearing the input from our specialists. I'm just, to kick us off, I'm wondering if I could just start by asking a couple of the words that came up that might not have been completely explained. So, and I can't remember who said it. It might have been, anyway, I won't shame you into telling you who said it, but we did hear it a few times, the idea of functioning and non-functioning tumours. So I'm wondering if someone would be so brave as to help us to answer that question, the difference between a functioning and a non-functioning tumour. Closest.
I think we did mention, I guess in the majority of it, functioning is really just producing some sort of hormone. Often that's the carcinoid syndrome that we talked about, producing symptoms related to carcinoid syndrome, but there are specific tumours, particularly some of the pancreatic tumours that produce other hormones that our endocrinologists keep very involved in, that may be gastrin, causing stomach ulceration, ACTH, that David's people who get any sort of more weight and other symptoms related to a particular hormone. So that's where we do rely on the endocrinologists to remind us, particularly in pancreatic neuroendocrine tumours, that we should screen for some of those things because they may not be symptomatic initially, but it's important to know if the tumour is producing a particular hormone. I guess the majority are carcinoid syndrome.
Fantastic. Did everyone understand that explanation? We've got it working well, so we need to pull up if they're not making sense. The other question I was just going to ask, just to kick off our multidisciplinary team discussion, and I'm sure there'll be more questions from the audience, but I wanted to ask a question of our surgeon. Susan has come to clinic, and the first question she asked is, well, if I've got a tumour on my liver, they cut the tumour out of my pancreas, why can't they, can I have surgery on this tumour in my liver?
Often with disease happening in a second site or metastatic disease after the primary's been removed, it's not just a question of is it technically possible, but is there a reason to do it from a survival point of view? So in general, we only want to do something like surgery, which is potentially dangerous and will potentially kill some patients, if it's going to make a difference in their survival, or if we've got a good idea that there's a really good chance it'll make a difference to their survival. And you know, the jury's really still out on resection for metastatic NETs. You know, there's a lot of early data suggesting that for metastatic disease in the liver that there is a survival advantage, but unfortunately that data is not very strong, and that because we generally tend to only operate on patients who are strong and healthy and probably are going to live a longer time anyway. So the data's all a bit biased, and so we have a general bit of uncertainty about operating on sites in the liver in general. And also Susan, you know, we've just got a snapshot now. We've only just seen, she's had 4 years of presumably very stable disease. Now suddenly she's got disease in her liver. You know, in 3 months, is she going to have disease everywhere else, or is she still going to only have one spot in the liver? And I think the sort of dynamics of the disease, if you like, make a big difference on which treatments and the amount of risks that you want to expose a patient to. You know, you don't want to expose patients to very, very high risk if the reward is very low.
Can I
Matthew, did you have a comment to make about that? We'll use the microphone so that the filming can hear us.
Sure.
Did you have a comment to make about that, Matt? Did I see your hand wave?
Oh, well, I was just, again, David explained it very well. I think that in some cancers we do surgically remove these secondaries in the liver because it's been demonstrated that it can help cure patients, i.e. the tumour's never going to come back anywhere else again in the future, but so often in neuroendocrine tumours it may be one spot at any one point in time, but we know from experience that over time other spots could easily develop, and so putting a patient at risk to remove one tumour and then 3 months later it's cropped up in the other part of the liver, you've clearly done that patient no favours. So that's really the sort of things that are going through our minds as to whether to operate or not.
Just a follow-up question, Matt. Would there be a benefit in doing a biopsy? So getting, she's obviously had some pathology testing done of the original tumour in her pancreas 4 years ago. Would there be she's asking, do I need to have tissue taken from this new liver tumour? Feel free to...
Biopsy is another invasive test, so there's always a risk to sticking needles in people. So we would try and, would often not do that. If we did a gallium dotatate PET, for example, and the tumours all lit up extremely avidly, plus there was other evidence that this was indeed a pancreatic neuroendocrine tumour rather than different cancers, such as a raised chromogranin level in the blood. So if the imaging and the blood work told us that this was the same tumour, we wouldn't necessarily go in and put the patient at risk with more invasive needles.
Thank you. So I've got other questions that I would like to ask, but I'm really keen to make sure we don't miss out on questions from our audience. So have we got anyone who would like to ask our panel a question? Hands up if you
I have a question.
Sure. No. If you tell me and then I'll repeat the question, it's probably best.
Now, at what stage does the team here decide that the patient is no longer viable for treatment?
Okay, so the question is, I guess tell us about the conversations that might occur in a team when they are deciding what treatments are appropriate and at what point a treatment is not viable. It's quite a tricky question. Would anyone like to describe the conversations that might happen in a multidisciplinary team context around those questions? Yeah, David, thank you.
I guess it's a bit easy to speak from a surgical point of view because often we get asked, maybe the initial question is this resectable or unresectable? Is it technically possible to remove or not? Is often a question that like David said, our MDTs are sort of linked, and they'll ask the question, and we can usually say reasonably easy, okay, yes, it's technically doable if you think it makes sense, or if we all think it makes sense to do from a cancer perspective. Or we say, unfortunately, it doesn't look like it's technically possible, and it may not be technically possible for lots and lots of reasons. So that's the initial sort of, I guess, surgical thinking, technically removable or not. And then often the discussion after that becomes much, much more challenging about whether or not it makes cancer sense to do more treatment. And then that's when the discussion usually spreads much more widely with these guys. So I can probably let one of the oncologists speak a bit more about the others, more of the decision making there.
That's an extremely difficult question to answer, and not something that you can just answer in a way that fits every patient, because it's going to be different for every single patient. Every inpatient situation is so different. What treatments they've previously had, how well they've worked, where the cancer is now, what it's doing, what other medical problems they have, what expectations the patient has, what side effects the patient's had. There's all these facets and factors go into that sort of decision, and it's a complicated discussion with the patient. It doesn't normally happen in one consultation. It happens over a long period of time. It's probably the best way I can answer it.
I was just going to add, I guess one of the keys for an MDT discussion is that the person who's presenting the patient's case knows the patient and has seen them. So in this situation, pretty much every neuroendocrine patient gets referred to our unit, Matt or I will see first. So we've already discussed this with the patient and we get an idea of a feeling of what the individual might want. And we'll go to the surgical MDT and I guess try and relay that back. I guess most MDTs in other tumours work best like that. It's very, very hard and you can make the wrong decision if you just get a letter and a scan and you put it up and you talk about it and nobody actually knows the patient and their circumstances. So we're a bit of a pain if somebody gets referred from CAMS that we might look at the pictures but we'd much rather see the patient, talk to them, get a feel of it all before we actually try to make those decisions because they're often discriminating.
Can I ask you a follow-on question from that? Often I talk to people on the phone and they've had a consultation with their doctor and they're thinking, gosh, how do I know my doctor's on the right track? Because I've been on the Facebook and there's someone else on the other side of the country and they seem to have a really similar situation, but their doctor told them something quite different. So I'm wondering if I can ask a question about second opinions and what that's like for you as a doctor, having that conversation if a patient asks you if they're able to have a second opinion, and how that kind of evolves. And I'm wondering if there's someone who would like to answer that question, or else I was going to see that maybe if David Pattison might be interested in putting the two bodies.
He's not the worst person to choose.
Okay, Amanda, it's yours.
Yeah, that's fine. Doctors don't mind if people want second opinions at all. Like, that does not bother us. We don't feel like our pride is wounded or anything like that. You know, particularly in an area like this, there is a lot of differences of opinion. You know, as Matt presented, there's lots of different treatment options. No one in the entire world knows the best order of treatments or any of those sorts of things. So, you know, to ask for a second opinion, of course, is fine, and you know, you just need to discuss that with your doctor. The problem is, I guess, that there's probably a limited number of people within your city who are very experienced in this area, and so, you know, it is important you see someone who has a lot of experience because it's you know, it is a relatively rare type of tumour, and to see someone who doesn't fully understand all of the, you know, ins and outs probably is doing a disservice rather than a service.
I was just going to say, one of the interesting things that I noticed about sitting in on multidisciplinary team meetings, and I've been to quite a few, was actually the amount of discussion and debate and collaborative decision making that happened in that meeting. So I didn't expect that. I thought that people would just be giving their recommendations and then that would be written down and, you know, that would carry forth. But actually, I guess it made me aware that there's so many nuances and it's quite complex, and often we don't have really good data. So there's actually often quite a lot of quite robust debate actually in the MDTs that I've sat in on. So that was interesting. Amanda, I'm just going to ask you another question. So this is about Susan. During the consultation that you've had with her, she mentions actually that her mum had a pancreatic tumour too, and that her auntie might have had something wonky with the pancreas, and actually there might be a grandparent also that had a cancer. Does she need to get genetic testing?
Yes.
Tell us more. Sorry, I gave you a close.
So, obviously, what Kate's referring to is that there are genetic syndromes that predispose people to these types of tumours, and I guess the main one is MEN1. Most people who have MEN1 actually present first with a problem with their calcium in their blood rather than with a neuroendocrine tumour, because that is the most common abnormality for those particular patients to have. And it really falls generally to the endocrinologists to manage these patients. We've got a very good set of guidelines, which EVQ is the name of the guidelines that we follow, and you can Google that if you want to. It suggests what sort of screening patients with a known mutation in that gene should have, so we can check those patients for the development of pancreatic neuroendocrine tumours, because MEN1 is associated with lots of different things actually, but the thing that can kill you really is the neuroendocrine tumours, and so that's what we need to be on the watch for. And I think one of the questions that Kate had said had come up in email questions was, should someone with MEN1 see an oncologist? Oncologists see people once they are diagnosed with cancer. They don't see people really in the lead up to that diagnosis, even if they have a genetic predisposition to cancers. And so I think if you've got MEN1, it's important that you have an endocrinologist who's skilled in the management of that condition and who is doing all of the surveillance that's recommended. Then that person will make the referral to the oncologist or to the multidisciplinary team when that's appropriate.
Thanks, Amanda. I'm just wondering if I could ask you another question, and that is, sorry,
It's okay.
I'm putting you on the spot.
That's good.
If Susan did have that significant family history and was referred to genetic counselling or genetic testing, what would be the time frame around that?
Sure. So generally, obviously it doesn't take terribly long to get in to see the geneticists. Usually they're pretty good with something like this. They would see someone, I would think, within about 4 to 6 weeks at the longest. But then once you've actually had blood extracted for a genetic test, you need to have 2 separate samples for gene testing, because they don't want any chance that it gets switched in the lab or something funny happens. So that if you're making a diagnosis like this, it has to be definitive. So you need to have 2 separate blood samples taken. They both get sent off, and the testing is performed to look for a genetic mutation or a change in the genes. If that is found, that probably takes, I think, about usually at least 6 weeks for that to come back. So you wouldn't have that information for that period of time, and then once that testing's back, obviously, usually it's the Genetic Health Queensland here in Queensland. They're the genetics team that look after all of the patients in Queensland who are having any genetic testing done, and they will then explain to you both in person and in writing the significance of the testing, and also obviously talk to you about the implications for family members, because obviously if you have been diagnosed with something that's hereditary, and this woman has, if she's got that many relatives, it's really very, very likely that she's got something hereditary causing the problem. And if that's the case, her siblings, her children, children's children, everyone will probably need to be tested. Yeah.
I'll just add on just one little point on that, which is that this is very, very important for those families where it is identified they do have a mutation. But overall, amongst the broad people with neuroendocrine tumours or pancreatic or pancreatic NETs, it is just a very selected population. They've either got a lot of family members who have the same disease, or who have these specific other tumours that are associated with it, or occurs at a very young age. So it isn't, not everyone needs to have blood testing, but it's those people who it's particularly relevant.
Thank you. There's a question over there. Daryl, go ahead.
Mine's about chromogranate. A couple of things. When does it become a concern, the level of the chromogranate become a concern that needs to be addressed? Secondly, in that, over the past few years, assays, I'd like to understand a bit more about what an assay is, and it has apparently changed. So if someone could talk about that. And then
Can we just stick with the first 2, because I've got a limited memory. So the first one is about the chromogranate A.
Yeah, when's the...
And when would you be concerned about a chromogranate A going up, or at what level? Is that, am I getting you right?
If you get concerned that it's really getting out of control,
And then,
urgent action needs to be taken.
and then what's an assay? basically, is that? Yeah. Who would like to?
Assay question.
All right, we're going to go to assay first because he's sitting beside me.
I was going to say the endocrine people know all about assays.
Oh, okay. And we'll go back to that.
An assay just means the specific way in which the laboratory performs the test. So there are lots of different ways that a laboratory could come to, a value. When you're getting, a result back, you've obviously got no idea exactly how they came to that result, but there are different ways of coming to a test result. And going into the specifics of that won't probably help you, but just when they talk about they've changed the assay, it means that they've just changed the way in which they measure that particular hormone or test, and therefore when they look at the normal range, it might be different. So, assay number 1, they might have had, up to 91 is one of the chromogranin assays, is the normal range is up to 91, and then they might have a second type of assay at a different laboratory, which has a slightly different normal range. And so, if you're looking over time at your chromogranin A, it might be that the normal range for that test changes over time as the assay changes. So that's really all that they mean by that. David, yeah, sorry.
I was just going to say in a practical sense.
Use the microphone if that's okay. Sorry, bossiness.
I guess in a practical sense in Australia, for many years, all that went to Tasmania to one laboratory, and the range was 35 or whatever it was. So everybody, public or private, had exactly the same assay. Yeah, the assays are sort of kits that pathologists use, and then a couple of other ones came in and the private labs started doing it themselves. And presumably, they'll make a profit out of that assay. So if you've got one kit that's worth too much, somebody else has a new one, and they can make it and offer it to you cheaper. There has been a change, so there's probably been 3 or 4 at least that I'm aware of over the last 10 years. And they do all have normal ranges, different normal ranges, and they're not directly comparable. So just because the normal range is 90 in one and 30 in the other doesn't mean double one of those is equal to the other test. So you've sort of got to start again to some degree if you compare.
Thanks. It's a question that I get on the phone too, where people say to me, what level of chromogranin A do I need to be worried about? And I'm like, well, it depends on which lab's done the test. So that's actually a really good question. And Darryl, did you have another question that...
just a very short one. Some people say that you should fast before you get your chromogranin test, and others, labs say, pathologists say you don't.
We don't have a pathologist on that panel. But yeah, preparation for chromogranin A should fast.
Yeah.
And there are medications also that affect chromogranin A out there. Would you like to talk about those? Or switch it again. David?
Well, really, the main medication is proton pump inhibitors, so things like Nexium, and they can interfere with the actual with that test result. They can falsely elevate that, and so it's important. Well, it depends. All patients don't need to stop that. Some patients need to stay on that tablet, but particularly if there's going to be a lot of value placed on whether the result is normal or not, then often people are advised to hold that for 2 weeks.
But I think it's also important to say that it's not the be-all and end-all. Like a lot of tumour markers, there's a lot of basically the lab always says to you this is a tumour marker. It's not a 100% test. I've certainly seen patients with metastatic neuroendocrine tumours who had a chromogranin A that was in the normal range, and often you see false positives of chromogranin A as well, so that they don't have a neuroendocrine tumour but it's elevated, and proton pump inhibitors usually the reason, but there might be other things. So I guess what I'm saying is you don't want to get too hung up on that number. The oncologists use it as a bit of a guide to see where things are going, if there's a trend. But I think getting really caught up on, oh gosh, it's gone up by 10 or 20 or, I don't think that's helpful, and I don't think that's sort of really relevant. You know what I mean? Yeah. Do you want to comment then?
So I would assume that when
We'll just let Dr. Wyld.
I was just going to reinforce that. There was a session at the European Neuroendocrine Tumor meeting this year. It was, is chromogram A dead? That's a monitoring test. And I think the consensus of people is that it isn't a great test for monitoring. Schellenberg from Uppsala said it's not dead, but it's nearly dead. And it's probably going to be a better test because you test it on somebody today and you do it next week, it can go up and down quite a lot. So just because one's gone up, it may well go down a little bit. And it's much more important about how the individual person's feeling, if they lost any weight, if they've got any other symptoms. And if their scans look the same and they feel fine, we don't need to do chromogram delays too often. So I think people would like it. It's not a good test for monitoring. We just don't have another test that's reliable. There's one called NET test that you probably read about that's been developed by a guy in the US who's been a NET researcher for years, which looks at certain gene signature. It's not practical for the majority of people. So they're trying to look for other ways of testing it.
So we take it with a grain of salt, but as long as we don't take it with PPIs, we're fine. Sorry, my poor attempt at humour. Before we go back to the audience, I had a question for our pharmacist, Paul. Susan, at this consultation with one of our esteemed doctors, has said her neighbour told her that high-dose vitamin C was the way to sort cancer out, and also gave her a bag of apricot kernels to munch on. And you know, she's come to you to get a prescription filled for some somatostatin analog injections, so she just happens to mention, because you've asked her if she's taking anything else, she just happens to mention these things. What do you say to her?
Normally, when you see a lot of people, you'd be surprised the number of people who are actually taking complementary medicines.
Should they tell you that they're taking it?
They absolutely should. Not all the time will we say, no, you shouldn't take that, and we don't want to hear you stop next time. That doesn't happen. Every year, more and more there's information available about what these complementary medicines will interact with specific drugs. The first place we go is to check online through a number of these sources to check what facts are known about what you're taking and the drugs you've been prescribed at the hospital. See whether there was a known interaction. In that case, then we would absolutely say better off stopping in this instance. That said, a lot of the complementary medicines, the evidence is still building up, not nearly as much as known about them as is known about medications in general and how the general medications interact. So we'd always, not tell people they need to necessarily stop, they need to consider how much they're taking, whether it's a mainstream complementary medicine or whether it's something that's out there that nobody has any idea about. There's a lot of nuance in deciding what is probably potentially safe to take and what probably should be stopped. But again, every patient is different. The drugs that they're taking for their treatment that are prescribed are different, and the complementaries that are taken is different. And it's very hard to general, like in a lot of instances, a general you should do this kind of statement. It really gets tailored down to the individual needs of the patient.
Did you have a comment to that too? No. Anyone else want to talk about that?
I guess we can say that apricot kernels are thought to be unsafe, which is probably the same based on guidelines from the US. And so probably not apricot kernels because they do have cyanide. So there is evidence around that one not being great necessarily. So we certainly rely on the pharmacist to try and look online and see if there are any interactions. And a lot of them we don't know, some don't, but there are some where you have known interactions with certain factors.
So you should tell your doctor or your pharmacist. Okay. Thank you. Let's open it out to to audience questions. Have you been? There's a question over here. Go for it.
I'm not quite sure which specialty to target this at, but with liver mets, can people talk about radiofrequency ablation, chemicalisation, and the radioactive spheres that are often in the literature?
Fantastic. So the question is for people with liver metastases, what's the role for embolisation and spheres and radiofrequency ablation?
I'll try and tackle that one. So they definitely have a place. They're clearly effective treatments. Got to try and pick the right patient in which to use them. So that would generally be a patient who only has liver metastases and doesn't have lots of tumours outside of the liver, which of course wouldn't be treated by these modalities. These tumours are radiosensitive, i.e. they do respond to radiation. That's why they respond to lutate. So the radioactive spheres, the SIR spheres, they can be effective. They usually, treatments are given by interventional radiologists who put the embolisation material into the hepatic artery through the groin, into the liver. When there's very bulky tumours in the liver, causing pain, they can be shunt considerably by these treatments, and they can significantly alleviate those symptoms. If there's carcinoid syndrome or another syndrome that's not being well managed by the somatostatin analogues, and there's bulky tumours in the liver, then that syndrome can often be well alleviated by these sorts of approaches. So they certainly have a place.
Can you explain the radiofrequency ablation, please?
That's basically where you just heat the tumours up. You put a needle in, and basically you heat them up and physically just destroy them. They have to be a certain of a radiofrequency ablation because of the radiofrequency probe and how much you can actually ablate. They have to be within a certain size. So radiofrequency ablation is not done through the artery to the liver, it's done through the skin, through a needle, and up to 3 centimetres is approximately the size of a tumour that can be well treated with radiofrequency ablation. Anything larger than that, we tend to be looking at the embolisation of the SIR spheres.
I was just going to have a quick comment just about these what we call liver-directed therapies, and that with any treatment it really depends on the ability to target what you're aiming to treat, and so with the embolisation it depends on the distribution of which artery can be embolised to block that, and whether that involves much of the disease. And one of the ways that in particular the main example I was going to use where I found to be particularly effective is in patients, you saw those scans, and if for example you're trying to target something with lutate, but there is that one spot that happens to be non-avid, for example, that's a role that can be very useful to selectively target if there's a more aggressive tumour, that can be targeted particularly by embolisation or the other liver-directed therapies.
One thing I was going to add to that with liver-directed therapies and surgery included, I guess, is that patients often ask as soon as they have visible liver disease, should I treat it? It makes sense, you see something, you just want to get rid of it or you want to kill it off. But what none of us really know for sure is that the timing of intervention and how quickly does any intervention make any difference to patient's survival. So the data today would suggest that there's really early intervention probably may not necessarily help, but intervening for specific indications like really hormone-productive tumours causing carcinoid syndrome or bulky tumours causing pain, that those things are valuable to do. But we still don't really have the full picture about when intervening is helpful. Sometimes we use, like David was showing, those 2 different PET scans. So if patients who've had long-standing gallium avid, which we think of as sort of well-differentiated disease, and then suddenly there's a spot in the liver which starts to go a bit crazy, and maybe it's FDG avid, then we think, oh, look, that's just going to keep growing fast if we don't sort that out, and that could be a life-limiting problem. So target that particular spot. But as a general rule, we try not to sort of suddenly see disease and treat it aggressively because it hasn't really been shown that that's making any difference to patients' long-term outcomes.
Fantastic, thank you. I was just going to ask Stephen, Susan's been talking to the doctors about PRT and she's asking you, well, her daughter's pregnant, is she A, going to glow in the dark, and B, is she going to be able to be near her daughter? What are the safety, and feel free to pass that on because I've got to put you on the spot, but I imagine this is a conversation you'd have with people.
Yeah, I mean, it depends on the timing of the therapy. So
Let's pop it up close to
if there was a
you.
critical need to do the therapy around the time of the time of the pregnancy, whether she would need to be there supporting, so that could potentially be deferred to after the baby's born, so that the mum could be there. What's the train of thought? It would depend primarily what she wants to do. So if being at the birth of the granddaughter is very important, we should try and facilitate that. We have radiation safety people that can chat to her and chat to the family. We would look at the arrangements, the living arrangements. Where is there room for her to stay settled? Talk about strategies for having limited contact but still being able to support her. Yeah, absolutely. And you know, key element is relating to planning, because often PRT is something that can be planned, you know, months in advance or certainly weeks in advance, and so that can be factored into to the timing around the birth. But in just a few general notes, perhaps about radiation safety precautions and PRT. It's not something that requires hospitalisation or isolation in general. So people will come in, have the treatment, and then will go home, and they're still, you know, out in the community. There's different radioactive treatments, not PRT, that do require someone to stay in hospital. And then the key question: there is still some radiation being emitted. So, you know, the next day, I wouldn't necessarily, although there's no strict precautions, I wouldn't be recommending to go and sit there and, you know, and hold a newborn baby. We would tend to advise there is still some radiation involved, so we would still perhaps, you know, minimise that. But the key things we talk about are time and distance, and so someone can still certainly go and see someone, but they just don't, you know, sit next to them, watch a movie for 3 hours with a newborn baby on their lap. So they can certainly be in the same room, they can get much of that experience, but it's just, you know, every time we double the distance, you go from 1 metre to 2 metres away, the amount of radiation that person's exposed to drops by a factor of 4. So, you know, there's these sorts of things that we discuss with patients. So it's certainly not a game changer. It doesn't mean that won't be a go and see anyone.
Thanks very much, both of you. I'm going to put it back out to the audience. Has anyone else got a question over there, Therese?
I get confused about gradient and the KI67. So sometimes you might see a questionnaire or say, what is your grading, as if it's a single entity, and then we also talk about you know, the diffuse natures of the tumours, and there's multiple tumours. So can somebody talk about that?
So the question was around what's with grade and KI67 and having more than one, possibly more than one grade in the same person, and how that all fits together. Is that?
Yeah,
kind of sum it up? Who would like to launch?
I guess we don't have a pathologist, and grading could be, in a strict neuroendocrine tumour sense, the grade is very much the slide that I won't show. Low mitotic rate, low activity tumours not really dividing. Low KI67 is low grade, intermediate grade, grade 2 is those 2 to 20, and then the high grade. One of the confusing factors is that grading system has changed 10 times over the last 30 years. So some of the other things which a pathologist says it's low grade, that actually just means what it looks like under the microscope. It actually doesn't. Sometimes I say the tumours, the cells look low grade, but that may not be the same. So there can be a little bit of confusion about the grade. In terms of, we know absolutely that tumours can be, you get sampling error, so if you take a biopsy from one spot and then you take a biopsy from somewhere else, it may be slightly different. So when pathologists do KI67, in theory, they're supposed to look at 500 cells, I think it is, so a representative sample of the tumour. And so that they're not just picking a low-grade spot or a high-grade spot. But if you've got a very small biopsy, then you can't do that. So you do have to be aware that that biopsy may not be representative. And if everybody's got cases where a patient's gone to have surgery and the pathologist has come back and said, well, one bit's low-grade and the other bit's sort of intermediate, grade 2, and it's not exactly the same. I think in the past people would take different biopsies, but we are now very guided by the nuclear medicine people and those imaging institutes. So we're sort of getting a surrogate of the 2 different PET scans, giving us an idea of do we think all of it's pretty low grade compared to other areas that may be more aggressive. So I don't know if that explains it or confuses it, but there are limitations when you look at, particularly a very small biopsy sample, but you just have to be aware that may not be representative of everything.
So, and the reason why they come up with these grades is because pathologists and clinicians have looked at thousands and thousands of people and all of that sample, and then they've looked over time and saw how that disease behaved in that patient. So there is a lot of value in that grading system that's been built up over decades of following patients when they've had that one sample and gives a figure. But I guess we're just highlighting that there are some subtleties and differences in a select population, and sometimes it can be pointed out by doing the going to taking FDG scan. But there are patients where there is that discordance, and that a different sampling site may actually tell a different story. And so there's certainly it's built on that paradigm of taking a biopsy sample, one sample, and following these patients over many years.
Thank you. Other questions?
Is there a difference in blood serotonin and the 5-HIAA urine serotonin? You guys tested, is there a preference for reason?
So the question is if there's a difference between the blood serotonin and the 5-HIAA test, the urine sample and the blood sample. And is there a preferred option?
Yeah.
They're all leaping at this question.
I would say that I would prefer a 24-hour urine test to get a better sense of whether the patient truly is producing more serotonin than they should be.
So what's the difference?
Well, you're testing basically the same molecule, but the blood test is one point in time. But the 5-HIAA is a breakdown product of serotonin, so you have to producing more serotonin over time to produce the 5-HIAA, which you're detecting in the urine. So I feel it's a better test of whether a patient is truly over-secreting serotonin or not.
I think it also depends on whether you're doing it to make a diagnosis or whether you're talking about monitoring, because the pathologist is set up the serotonin, blood serotonin. My understanding is it's very variable, so if you leave it sitting on a bench after the blood's taken, you don't store it in ice and you do all these other things, it can go up and down. So I think if somebody's got a tumour in their liver and you think they might have carcinoma and you do that test and it's really high, it's useful. I don't think it should be used for monitoring, because the other thing is, my understanding is it goes up to a certain level and then it can't go any higher. So even if your tumour's getting good, the serotonin will just bubble around a certain level. Whereas the HIAA is good, but it's a pain in the ass to do because of all the diet and collecting and things like that. So again, it's a good diagnostic test, but I guess we're not. Some people, some centres do them regularly. I guess we do them less regularly because they're just so difficult and nuisance.
Can I maybe ask one of our endocrinologists is wanting to talk as well, but I'm going to just ask you, are there other things that can raise those levels?
Yeah, there are. I mean, so there's dietary things. I mean, with serotonin, there's things like caffeine, etc. There's particular, fruits as well. There's a whole list of things. There's avocado, a variety of other, fruits that will elevate those levels. The main point, and you get given the list when you go into the test what the particular requirements are. I mean, the key thing I was just going to say before is that the 5-HIAA level that's been around for a very long time, and so it's been used, and there's a lot more knowledge about what that test actually means. Whereas the serotonin is a much newer test, and it bounces around a lot, as has been alluded to already. And there's much less sort of understanding of exactly where the cut-off and threshold should be to define something like carcinoma syndrome. So I think, in my preference, I agree that the urine 5-HA test is a better test. It's like an average of your serotonin level, rather than just looking at one thought.
Thank you. Other questions from the audience? Yeah.
Because of the difference between your gallium-68 dotatate and the FDG, how is the decision made which scan you would have to have?
So the question is, given that the gallium-68 PET scan and the FDG PET scan measure slightly different things,
Yeah.
how do you decide which scan to use? Is that, have I got you right?
Or should we sort of be alternating or something?
Yeah, okay.
Yeah.
Do you want to? Yep, David?
Yeah, I mean, I wouldn't just alternate from one to the other. I mean, there's particular reasons. I mean, I went through the several slides that I looked at just for particular reasons why you might do one or the other test. In neuroendocrine tumours, the most commonly performed test would be the dotatate PET scan. The doctor who you were seeing at the time, they will only do a test if there's a particular reason, there's particular information you want to get from that. And so that would inform the decision. But in general, the FDG scan, it's only done in a selected population of patients. We don't do it in everyone, and it's only if there's any of those triggers for a suspicion that the tumour might be growing faster than expected or behaving a little bit differently. So it relates to that Ki-67 value, or if the growth rate has been faster than anticipated, or if there are particular spots identified on the scan that would prompt them to think that it wasn't taking up the dotatate tracer and they do the FDG.
Can I ask alongside that, I often talk to rural patients who they're having CT scans and ultrasounds and MRIs as well. Comment?
Well, there can be different reasons for that. So one can be that they're, the appropriate tests or what they're looking, they're following particular lesions, and that will give an indication over time as to how things are changing. So that can be, perfectly, appropriate testing, availability can be an issue sometimes, and so, if the particular question is in a rural area, maybe that they don't have access to that test. But in terms of the precise number of these scans that need to be done and what impact that actually has on management, on clinical outcomes, is not really well established. So I would think it would be useful at some point to have a dotatate scan in many patients, but it doesn't mean that it needs to be the primary mode of follow-up.
Other questions from the audience? Question down the back.
Yeah, I just obviously, we're looking at the tumours and the sort of endpoint sort of things. Given that it's a systemic thing in the endocrine system, I was just wondering, having spoken to nutritionists and so on, about any research or evidence about, interventions on that level, on the system level, that can make a difference other than just sort of, treating the tumour at the end. Is there any, it's hard to sort of find ideas about that. Is there anything that people know about that?
So the question is about diet.
Oh, that's one, for sure.
And if there's anything else more broadly that you can be doing to prevent the growth of that disease, apart from what we're doing at the hospital. Yeah, good question.
Just give a general answer to that. I mean, I think this is something that everyone is focused on, but I think sometimes people can not necessarily focus on the things that we do know. And so the key, whenever I get asked that question, I just go through the points that, we generally know what a healthy diet is, but we don't all necessarily follow that general advice. And so I think that's one element. We know that, trying to exercise for 30 minutes 3 times a week is really important and valuable for our health. We know also that in general there's not as much literature about this, but avoiding stress and getting adequate amounts of sleep, these are all really important things that are practical, that help our well-being. And sometimes I think these things can be overlooked and looking for a magic bullet sometimes. But that except, there is a lot of research, and there are groups that are looking into things and other diets. I'm not across all of the issues in particular, doctors you could look at, but I'll speak to you about that. Someone else might have more comment.
I was going to plug it at the end, but I'll plug it now because we actually have hot off the press this week a new booklet on nutrition and neuroendocrine tumours. And it's, look, I have to say, it's not so much around anti-tumour diets, although that has been addressed in one of the webinars, which is on our website, so it's worth having a little look at if you're particularly interested in that. But general guidance around nutrition and neuroendocrine tumours, and particularly around things like carcinoid syndrome and managing some of those symptoms. So it's worth having a look. There's some over on the table over there, so I'll stop plugging. That's a question. Someone else ask a question while I think of mine. Yeah.
At what point in disease progression would a patient be referred to the multidisciplinary team, or should be asked to be referred to if they're under the care of a single practitioner?
That's a great question. So the question is, at what point, if you're under the care of a single practitioner, at what point would it be best for you to be referred to a multidisciplinary team?
I mean, I guess we're in a situation, everyone sitting here is in a situation where if we have any concerns with any of our patients that we would like our colleagues with a wealth of information, we actually, we have a very low threshold for taking people to our MDT. So I guess we're the wrong people to ask, that question of, because actually we have a lot of discussion between us to work out what the best option is for a patient. If you're under a private doctor who doesn't have perhaps access to the multidisciplinary team, I think if you've got any concerns about that management, you could ask to be referred, but it means that you probably have to see someone who's at one of the hospitals that has a multidisciplinary team, because it doesn't, as David said before, we don't want to make decisions if we don't know the patient, and so it's sort of important that at least one of us has actually met a patient who we're referring to the MDT, and that we have a good understanding of their particular issues that we can discuss. Does anyone else stay?
It sort of depends on the individual circumstance as well, because certainly there are a lot of people around who have a biopsy now to have a neuroendocrine tumour. That may well be discussed with local surgeons and whoever it's not operable, and they started on somatostatin analogues, and that patient may be stable for years. And so we probably see a lot of people who are then progressing after that via treatment, and often, for better or for worse, coming to us for an opinion about PWRT, because that's what we do. But I guess if that has been discussed at the beginning, you're honest and understand that everything's very stable, and maybe having that discussion, there isn't really anything to add at that point, as long as the person is engaged and is thinking about all those other options. But it's often that decision, something's changing, what is the best approach, and getting a variety of different opinions about what might be the right thing to do at that time. And David will talk about the ways they obviously have MDTs where there are lots of surgeons and oncologists there, although he can probably explain that better.
I was going to ask while I'm passing it over, where are the MDTs in Brisbane? Because I know there's one at Royal Brisbane and there's clearly one at the Wesley. But yeah, maybe you can answer.
Is there anywhere else? No, yeah. I'm sure on the south side of the river they have doctors as well. No, to be honest, I'm not sure of the mechanics of the PA and Green Slopes and the other bigger hospitals, but I'm sure that we have some sort of access to it. From my point of view, we all probably see different little snippets of patients with neuroendocrine tumours. In general, the most common patients I would say have come in an emergency with a small bowel tumour, which is obstructed, or they've done something funny, or they've had a CT scan or an ultrasound or an MRI which showed a spot in the pancreas. And then, because we're talking about surgery, which is a big intervention, I would generally refer almost every patient to an MDT for a discussion before we do that kind of surgery. And also because, for example, in pancreatic neuroendocrine tumours, which I see a lot of, we're doing, or I'm certainly doing, more and more conservative management of small tumours. So if we see a patient with a small 1 centimetre tumour in the pancreas that we're planning on just observing, obviously it's very good to have other opinions from many colleagues to say, yes, observation is an appropriate mode of treatment here. Because it's controversial. Some of these things have been argued about for a long time. The North American guidelines and the European guidelines don't even always agree on what the best thing to do is. So it's hard for one poor surgeon to make that decision. So I think it's best to get a few opinions. And also, of course, every single patient is different. And some patients, mindsets are different about their management. Some patients are very, very risk averse and really don't want any sort of hands-on treatment. Other patients want very, very active treatment, and you kind of have to modify your approach depending on the patient as well. So yeah, and I'm sure Amanda probably sees a lot more patients with MEN, and their disease is often very, very different, and their risks are very, very different. And again, similarly, oncologists probably see the biased group, which is more advanced patients, and David probably sees patients with very advanced disease who are looking for PRRT. So we all see different snippets, but so thresholds are probably a little bit different.
Thank you. I'm just going to put you all on the spot, and I'm not wanting to reveal anyone's age. I'm just wondering if we can go along the row and you can tell me approximately within a decade or so how long you've actually been practicing your craft. So, David, how long have you been?
I'm about to go to David's 40th birthday.
So how long have you been a surgeon?
I've been a surgeon since, good question.
2001 we finished.
For about 12 years,
so about 12
probably
years.
Sort of subspecialist HPV surgeon, or pancreas surgeon for more sort of 6 or 7 years.
Okay, so let's call it conservatively 6 or 7, and then does someone who's good at maths do a running tally for us, Amanda?
Yeah, I've been a fully trained endocrinologist for 7 years.
So it goes 7 again. And David, how long?
For about 6 or 7.
6 or 7, okay, so maths brains. Stephen, how long have you been a nurse?
23 years.
23 years.
2.5 years as a nurse.
Yep. And Paul?
11 years in
11.
care.
Helen?
I've been a nurse, a registered nurse for 35 years.
35.
Oh, sorry,
We're keeping track. Someone counting? Matt?
13 years an oncologist, 23 years a doctor.
So 13 or 20, let's give a range. And David?
A long time.
A long time.
I've been in Brisbane 20 years.
20 years.
From the UK.
So we've got a tally?
133.
133, 135. Any advances on 135? So that's a lot of years of experience and expertise in the one room. So I guess that's what you're getting when you have a referral to an NDT. You're getting that combined expertise. So that I just always find that quite amazing, quite staggering actually. Questions from the audience, more questions. We've got, we are almost at time, so this needs to be the final one. Has anyone got a burning one? I've got another one if there's no but one from the end there, from the back.
What's your view on medical grade cannabis oil, please?
Oh, good question. So the question is about medical grade cannabis. Who would like to enter the fray? What was that? Who would like to answer? I just call that David rather than answer.
Only because I think my experience is probably similar to these. We don't get a lot of information about it. It's hard. I mean, to be honest, there's not exactly
well, you've got a
clarity.
room full of volunteers to
Yeah, I mean, in principle, I have no problem with it, and it's just a matter of lots of patients are starting to ask. Actually, I think because it's more and more in the news. But I mean, as far as availability or legality, I mean, I honestly don't know. It's not something that we get much information about either. So, but maybe that will change over the next few years. I would hope. I don't know.
David Wyld, and maybe have we got a pharmacy opinion on the way through?
I think it's important to be aware of the differences. There's a lot of cannabis use in the US And a lot of talk about, oh, it can cure this, can cure that. That is absolutely not the case. It can control some symptoms, it can absolutely prove some nausea, it has some effects outside of cancer. But you really need to differentiate what exactly you're asking. If you're hoping for a cure, you know, you find lots of the internet, that's just not going to happen.
Can I ask a question?
Let's get a comment from David, because he's...
I was just going to say the same thing. I mean, the guidelines in Australia are for pain, palliative care, for uncontrolled epilepsy, for other things, and potentially for nausea for chemotherapy. But the nausea for chemotherapy is based on data from 20 years ago. One of our colleagues was in Canada doing a fellowship when they were using it. We didn't have any of the anti-nausea medications we have now apart from Maxol. So that was the only thing it's being compared to. So the guidelines, the official ones, it would be if it failed other standard antibiotics. So, but the NCI in the US have certainly done their study that says there is no proven evidence at the present time of an anti-cancer effect. So it's not going to be licensed legally in Australia for an anti-cancer effect. It'll be pain or nausea and epilepsy. And a couple of states have got trials, which I think New John's out on weekends on the front page of the paper, and one of the oncologist there that Matt's climbing up a mountain next year said he's going to run a trial there for it. But Queensland don't want to put any money into a trial, and we're not allowed to refer people. We're not allowed to do the Sydney trial. So I think it's going to still be the way away at the moment.
And do we know of any interactions, Paul, in terms of with other drugs?
Off the top of my head, no. There are with some patients with taking medication for mental illness and a few other things, but cancer specifically, there's nothing that is going to cause major problems. Again, but the dosing is quite specific in control of the etc. And the preparations are quite different to something like
and at the moment, the cost to use the official invoice is, I think, somewhere between $1,000 and $2,000 a month. So you're told. Quite expensive.
Currently, no, it's produces with the cannabis. There's a certain number of crops being sown, I guess, at the moment, but the government have made it quite difficult for license, in terms of licensing, etc. So it's maybe a little way on for anything local.
So I'm hearing the take-home message is proceed with caution, especially if there's an ethical issue. I'm just going to ask one more question, and I'm sorry I'm going to put you on the spot. If I've got a neuroendocrine tumour and I want to take some cannabis and I've spoken to someone, not via the Unicorn Foundation private discussion group or anyone else that we know, but I've got some and I'm taking it, and we've just talked about alternative complementary therapies and how we should tell our doctors about it, but this is not legal. So if you're told about this, are you going to take us to the cops?
We ask about this all the time. We're going to take anyone to the cops. We're not interested in taking people.
Not interested in taking people to the cops. So the take-home message is if you're taking anything extra, then you should tell your doctors.
Correct.
Okay. Look, we are going to wind this section of the evening up because we've still got just a little bit of other stuff to cover. But can you please join me in thanking our panel?